from you as patients, we have to go over, which is the use of blood thinners. Oral anticoagulants, blood thinners, anti-clotting drugs, they're all the same. And there's a lot of misconception about it, particularly since lawyers get heavily involved with these things. I mean, how many of you have seen the 1-800 bad drug if you take a Xarelto advertisement? Of course, they don't tell you when people die, when they have huge strokes, when they come off those things. You know, you wonder who gets sued in those things. So let's talk a little bit about stroke and atrial fibrillation. I presume everyone here has had an episode of atrial fibrillation, at least once. Many? Some many. How many are on blood thinners? How many have been advised to take blood thinners and just won't take them? Well, nobody will admit to it. So, you know, the reason we have to worry about, you know, we always say it, our nurses get sick and tired of hearing it, but we always tell patients, and this is for some a revelation, that Afib never kills anybody. I've never seen Afib kill anybody directly, but I see at least once or twice a week the huge strokes that sometimes result from Afib. And the reason is when the upper chamber, which is, we call it the atrium, in Latin that means vestibule, so that's the receiving chamber. The atria, or the receiving chambers for the blood that comes back from the lungs and from the body. They basically transport the blood down to the main pumping chambers, the ventricles. But when those atria fibrillate instead of squeezing, what happens is the upper chamber quivers and blood stagnates. Okay? There's stagnation of blood in a structure called the appendage. Unfortunately, we didn't bring the heart model. So that's why we have more risk of stroke in AFib. And a lot of patients will say, well, that's probably just a minor thing. I can take a little aspirin. It's not a minor thing, because when you look at the data, patients without non-valvular AFib versus those with it, the risk is roughly 5 times as high to have a stroke. That's the number you may want to remember. It's 5 times higher if you have AFib in the Framingham Heart Study, which is one of the biggest studies ever published. So it's a 5-fold increase. That's at 2 years. So the risk goes up. So every year you're not treated, the risk goes up. And how many of you have family members that have had a stroke? Not a pleasant thing, is it? Because part of what makes you you is no longer there. It's gone. So basically what we do when Dr. Zhao and I sit across from you and say, we think you should go on a blood thinner, we're basically choosing the lesser of 2 evils. By asking you to do that, we're asking you to take a risk. What's the risk? There's always risk and benefit in every proposition. The benefit is if you take the pill, you won't have a big stroke. What's the risk? We expose you to risk of bleeding. So we're basically asking you to trade one bad thing for the risk of maybe another bad thing. In the ideal world, you took a pill to prevent a stroke, but it wouldn't cause any bleeding. We don't have that pill yet. Some come better than others, but we don't have that pill yet. So there's always an assumption of risk if you get treated with these medications. That's a big trade-off. So we know some patients are at higher risk for stroke. So many times if you look at your chart, you'll see a number we put called the CHAD score. Okay? And the CHAD score is a risk scoring system that tells you, roughly what is your risk of developing a stroke if you have AFib. It has several components. The CHADS is an acronym for congestive heart failure, high blood pressure, age over 75, diabetes, type 1 or type 2, or if you've had a prior stroke. If you've had a prior stroke, they weight that differently. They give you 2 points for that. Okay? So our typical patient is probably 70 to 80 years old. Let's say they're 77 and they've had diabetes and high blood pressure. That's a typical scenario. Let's calculate a CHAD score. Well, they're 77, so their age over 75, that's 1. They're diabetic, and patients say, well, I've got great control of my diabetes. It doesn't make any difference. The very presence of diabetes is a point. And high blood pressure, well, my blood pressure is 120 over 70 today, but it's still, you're diagnosed with hypertension. That's how the trials looked at it. So what's this patient's CHAD score? 1 for high blood pressure, 1 for diabetes, 1 for age, CHAD score is 3. And so in studies of thousands of patients, what they've done is they've calculated what the risk is per year with a CHAD score of 3. It's roughly 6%. Okay? The bad thing about talking about risk is that risk applies to lots of people. These numbers tell you what happens if you look at 100 patients, but it doesn't tell us what happens to you. Medicine is not that good. Medicine can never tell you what happens to you. It can only tell you what happens to 100. That's why when we talk about risk, it's kind of a very tricky thing, because if you're the one who has a stroke, let's say your risk is 1 in a million and you're the one, you know, what's the risk of a doctor being in his office and getting shot to death? Well, it's less than 1 in a million, but for that particular doctor a week ago, it was 100%, right? So this is roughly how we approach you and our urgency in getting you to take a blood thinner, okay? Let's say you've had a prior stroke and you're over 75 and you're hypertensive, that's 2, 3, 4, that risk is almost 9%. So the more risk factors, the higher the risk. That's what we call the CHAD scoring system. It's been amended lately, it's called the CHADS VAST scoring system, because they've added the fact that women tend to have higher stroke risks. So if you're female, they add another point. And if you've had any vascular disease, let's say you have carotid disease or coronary disease, they add a point. And in that scoring system, they start breaking the age down earlier. So if you're 65 to 75, it's 1 point. If you're over 75, it's 2 points. It's just an addendum to the risk factor profile. So a lot of times patients will ask, well, what is my stroke risk? Well, we can give you pretty accurate numbers based on studies of over 50. This study was 1,700, but it's been replicated thousands of times. The numbers roughly follow the same kind of law. Does that make sense? So some patients are at higher risk for stroke. What about a 40-year-old guy who doesn't have any risk factors and he's in persistent AFib? He's in AFib all the time. What's his risk score? It's almost 0. It's never 0, but it's close to 0. In that particular patient, we may not put them on blood thinners. So I just want you to know that the decision to ask you to take a blood thinner is usually not a whim. It's usually reasoned out. Okay? That's called a CHAD scoring system. That's what we use to do this. Now, let's talk a little about Coumadin. How many of you have taken Coumadin? Yeah. Okay, Coumadin, what was Coumadin? Coumadin was incidentally discovered to be a blood thinner. There was a fungus that grew on moles in the farms in the Midwest, and it was found it killed rats. Coumadin was developed originally as a rat poison. Okay? So you put enough on there, the rats would bleed to death. But Coumadin is the mainstay of stroke prevention. So I don't know, I can count all these numbers of patients who've been in these trials. If you're on Coumadin, it drops your risk for stroke anywhere from 54 to as high as 78%. It never takes it down to 0. And that's the key point. So the original blood thinner developed to prevent stroke never takes the risk down to 0. So can you have a stroke on Coumadin? Yes. Can you have a stroke on any of the other blood thinners? Yes. These drugs are relatively protective. They're not absolutely protective. That's one thing to remember. There's no single agent that takes the risk of stroke in AFib to 0. Okay? So as a basis of all these trials, Coumadin became the de facto preferred drug to prevent stroke. Okay? For years and years and years. When I was a med student, when I graduated in '82 from LSU, all we had was Coumadin, right? That's all we had. Up until just a few years ago, we had newer agents, and we'll talk a little bit about the newer agents, but Coumadin was the mainstay. Now there's trouble with Coumadin, and so this is a very complicated slide, and what it tries to show you is what it takes for you to form a clot. How does your body protect itself from bleeding to death if you're brushing your teeth and you start bleeding from your gums? That simple act actually requires a lot of physiology to keep you from bleeding, because you could ooze continuously if your body didn't clot. Okay? So for a clot to form, we'll go back to this top later, a substance called fibrin has to be formed from this precursor called fibrinogen, and to do that, it takes this precursor called thrombin, and this is going to become important when we talk about the other agents. And then on the other hand, it takes a whole host of proteins in the blood to come together on this factor 10A to drive this. Okay? So what does warfarin do? If you take a pill of warfarin this evening, let's say you've never been on warfarin, what does warfarin do? It blocks these proteins from being formed, and if you don't have enough of these proteins, you can't form a clot. So it prevents these clotting factors from being assembled. So how long does it take for warfarin to work? Let's say you go into Afib tomorrow and you see in the emergency room and the doctor starts putting you on warfarin, Coumadin. How long does it take that Coumadin to work?
3 days.
Well, it can be from anywhere from 2, 3, 4, 5, 6, 7 days. However long it takes you individually to not make these clotting factors. You have to deplete the clotting factors. Okay? You have to deplete the clotting factors. So you're not protected. So what do the doctors usually do is they give you another medicine called heparin, or its more modern form, Lovenox. Anybody ever been on Lovenox? So that's called bridging. So while they're waiting for Coumadin to take effect, they bridge, they provide protection with something called Lovenox. There's absolutely no data in the medical literature to know that that works. There's no information at all. Everybody does it. It's one of those things we do because it makes sense, but there's very little data that bridging actually does anything. Okay? That's how Coumadin works. So you're not protected if you go on Coumadin. It takes up a few days, right? And these factors are many times vitamin K dependent, so you can overcome the effects of warfarin by ingesting vitamin K. Okay, so if you take a vitamin pill that has a lot of vitamin K, what does it do? It counteracts the effect of warfarin. Or if you go to a nice Italian restaurant and have that big juicy, you know, I love, it's one of Venetia's, that Italian salad Venetia's, full of tomatoes and greens, that'll overcome the effect of warfarin. That's why it's so hard to keep the level of warfarin at a constant range. It bounces up and down because of what you eat. Okay? That's how warfarin works. The newer agents work down here. They directly bind to one of these factors, either factor 10A or thrombin, and we'll go over those newer ones in a little bit. But once you take one of those medicines, they instantly go across the stomach, into the bloodstream, and they bind to these, and they're effective right away, just like that. So if you develop AFib, and so I haven't taken anything in years, and I've got a bottle of, let's say, Pradaxa, and you take one Pradaxa pill, you're effectively, your blood is thinned. Unlike Coumadin, which can take 3, 5, 7 days. Okay? So I don't usually like to put this thing in here, but you can't understand how these things work unless you realize that it takes these proteins in a chain reaction to actually generate something that forms a clot. Now what does aspirin do to this? Nothing. Aspirin does nothing to this. Aspirin works on the platelets that drive clots in a different way. So taking aspirin doesn't affect these. Aspirin will never be as good at preventing stroke as warfarin or the new drugs. So that's a common question we see in the clinic. Why can't I just take an aspirin? Because thousands of patients in multiple studies, it doesn't provide much benefit. Okay, it's like spitting into the wind. You get a little bit of effect, but not much. So aspirin by itself is not enough. You've got to take either warfarin or the new drugs we'll talk about. And the new drugs, before we get to them, I'll say a couple other things. So one of the major dilemmas in medicine nowadays is that a lot of doctors are afraid to prescribe blood thinners. Why? Because they're afraid to have you bleed. Or if you're older, they're afraid if you fall, you're going to hurt yourself real bad. But if you look in this, let's go back. If you look in this country, only about half the patients who need blood thinners are prescribed blood thinners, because primary care doctors in general are afraid to use them. Plus, warfarin has to be monitored. So only about half the patients in the country that need them actually get them. But the other important thing is that if you look at the number that measures how thin or thick your blood is, anybody know the name of that number?
2 to 3?
Hmm?
It's between 2 and 3?
That is, but what's the name of the test?
PT-INR?
INR. The INR is only in the right range about 50% of the time. Okay? That number is called the time and therapeutic range. So what that means is that on one day they may take your INR and it's 1.8. Another day they may take it, it's 3.4. It tends to bounce up and down. So what happens if your INR is 1.5? You're not getting enough protection. Your blood is not thin enough. What's your risk? If your blood's not thin enough, you risk stroke.
Right.
On the other hand, when it gets above 3, the risk of bleeding goes way up. It's almost exponentially up. So if it's 3.5, you run the risk of bleeding. So you can see why this is a drug that maybe is not the ideal drug, right? But it's the mainstay. So only half the patients who need it get it, and of those who get it, only half of them are in therapeutic range for any significant amount of time. We've got several patients, no matter how much Coumadin we give them, we can't get the INR above 2. And other patients, they take 3 doses of Coumadin and the INR is jumping up to 5. And they come into the emergency room with bleeds. It's a very difficult drug to titrate just right. Other patients, it works just perfect. Okay? After 5 days, their INR is 2.3, and you check it month after month, it's 2.4, 2.3, they're perfect. So some people have an easier road with Coumadin than others. But in general, only half who need it get it, and of those who get it, only half are in therapeutic range at any one time. So again, if you go eat that big salad, you know, you counteract the effect, you're more at risk for stroke. Okay? And of course, medicine's affected. What's the other big downside of warfarin? You got to go get it checked all the time. How many times have I heard patients complain, do I have to keep getting the INR checked? Well, we're putting you on a new medicine, interacts with it, it makes you more prone to bleed, we got to check it more. Believe me, we don't revel in having you go get more blood tests. But that's the bottom line on Coumadin. So for years, we begged, as clinicians, we were begging industry to develop some new drugs that would be better. And they did. They developed 4 new ones. I've listed 3 of them here because these are the ones we use. The first one was dabigatran, called Pradaxa, and then came rivaroxaban, also called Xarelto, and then the third one was apixaban, also called Eliquis. I'll leave that up here so you can write that down if you like. Because how many are on Pradaxa? Okay, how many are on Xarelto? How many are on Eliquis? Okay. We'll go over the pros and cons of each one of them, but those drugs work in a different way. Remember we said that for a clot to form, you had to go through this chain reaction of proteins coming together. Warfarin depletes these, so their concentrations go down in the blood. Pradaxa is a direct thrombin inhibitor, so when it binds, when it chemically latches on to that molecule, it renders this ineffective. So this is one of the last chains in the chain reaction. So this is how Pradaxa works. The other 2 drugs, Xarelto and Eliquis, bind to factor 10A. In any event, they're binding directly to these proteins and rendering them ineffective. So these are examples of designer molecules. We've got some brilliant chemists working in industry. They design these drugs specifically to go counteract these agents in the chain reaction. So again, from the time you take it, that molecule is absorbed across the gut and it binds to either this or this. It means you can't get this to this and you don't clot. Okay? So these are the designer molecules. We call them the NOACs, novel oral anticoagulants. And we'll go over the pros and cons of them. One advantage is that they're very effective. Of course, if you're just on a procedure on someone, you don't want to take this right after because you'll bleed. So the risk comes with some benefit. So let's talk a little bit about them. Pradaxa prevents clot formation by selectively binding to, it's a direct thrombin inhibitor. It blocks that step, and we get effect. Now, I'm not going to go through everything about each drug, and at this point, I'm basically going to tell you what the studies tell us about these agents. I'm going to summarize a huge amount of data. But let's look at some data for Pradaxa because it was the first one. I'm going to go to the clinical trial. And what they did in this trial is they took 18,000 patients and they took a population that was at high risk for stroke and they randomized them. What does randomization mean? They put them into different categories. So for some of the patients, they gave them traditional warfarin, and then the other patients, they gave either Pradaxa in this dose or Pradaxa in this dose. Now, what they found is they would design these studies to be as good as. They wanted to see, is the drug as good as Coumadin? What they found was, if you look at the probability of having a stroke, you had a 35% less risk of having a stroke. And this is a consistent theme across all the new drugs. They consistently are going to provide better stroke protection. Okay? In every category, Pradaxa provides better stroke prevention. Xarelto provides better stroke prevention. Eliquis provides better stroke prevention. And so in this case, it's pretty dramatic. Now, what's the trade-off for that? Remember we said there's risk and there's benefit. So a lot of patients will say, well, which one is better? You know, is it Coumadin better or Pradaxa is better? Well, if you're looking at the endpoint of stroke, Pradaxa clearly is better to prevent a stroke. What do we trade off with Pradaxa? Let's look at bleeding. Okay, let's look at strokes. The other big thing is that you had the stroke reduction, but look at bleeding strokes. These are the bad strokes where you bleed into the brain. There was a huge reduction in that kind of stroke. Okay? So it not only provided better stroke prevention in general, but there was less bleeding strokes, which tend to be big, ugly strokes. So there are a lot of reasons why it was better than Coumadin. Now let's look at bleeding. Again, there's a consistent theme with the bleeding. Okay? You tend to bleed in general a little bit more, particularly in GI tract. So the trade-off when we use these drugs, except for Eliquis, which has a lower risk, if you look at the drugs in general, much less risk of intracranial brain hemorrhage, but in general a little higher risk of bleeding into the GI tract. That seems to be a consistent theme. More bleeds from the gut, less bleeds into the brain. So this is the dilemma we face when we counsel you about what's the best agent. Is it Coumadin or one of these drugs? Now, there have been no comparisons among the new drugs. Okay? You can't compare apples to oranges and oranges to bananas. There's no direct comparison. Nobody's ever pitted them in the same population one against the other. So technically speaking, we can't tell you which one is the best, but we do have our ideas about which is best for certain situations. Okay? So this was Pradaxa. Now, the other thing about these drugs is that, in general, up to recently, they did not have an antidote. A lot of patients read a lot and they ask me, what about the antidote? Well, we have an antidote for Coumadin. Anybody know?
Vitamin K.
Vitamin K or fresh frozen plasma from the blood bank. I think I'd rather get the vitamin K, but fresh frozen plasma will do it also because it's got those vitamin K depleted factors. Up until recently, there was no antidote for these new drugs, but Pradaxa recently came out with one that works very effectively. It's called Praxbind. You may have heard of it. It's been advertised, Praxbind. So there is an antidote for Pradaxa, and there will be antidotes for the other two. But I'm using Pradaxa because it was the first, and I wanted to get some themes across. So when we counsel patients about these drugs, what we can tell them honestly is that in the studies, patients had less risk of stroke, 35% less risk of stroke. They had less risk of bleeding type strokes in the brain, but they had a few more bleeds in the GI tract. Okay? If you look at fatal bleeds, although it rarely happens, it does happen. We had one in our practice recently. It does happen. If you look at fatal bleeds, it wasn't statistically that different. Okay? So this is the risk and this is the benefit. When we ask you to take this, we're trying to protect you from the stroke risk because we think that if you have a bleed, you can survive the bleed. Because if you have a stroke, in most occasions you can't survive the stroke. You're left with whatever damage is done to the brain. So those are the themes I want you to take home when you look at these things. Now, I'm not going to go through all the technical aspects of it, But there was one aspect that I want to go over with you. It's in these slides. When in this trial, they found out that when they switched patients from Pradaxa to Coumadin, there was a big spike in strokes. Why do you think that happened? Remember I said it takes several days for Coumadin to take effect? So if you stop Pradaxa and you start Coumadin, you're exposed to that risk over several days. I think that's why it happened. So I'm not going to go through every drug because we're going to take that into question. So what I've tried to do in a very brief way is give you some insight into why stroke prevention and AFib is so important, and then tell you the role of Coumadin and now the new drugs. So at this point, I'm going to take some questions because the questions many times are more revealing than a lot of technical details. So a common question we get is, let's talk about some of the problems with the new drugs. What do you think the biggest problem we have in the office with trying to use these new drugs?
Too costly.
Costly. Okay, like any new drug, you know, I'm not a big fan of the American pharmaceutical industry because I think in general they gouge patients here in America to subsidize Canada and Western Europe. And I think we get taken. And I think so I'm not a big proponent of big pharma. But the biggest problem we have is that patients can't afford them. Coumadin is cheap. Coumadin is generic. You can get Coumadin probably for $10 a month. It's very inexpensive. $5 you get on your plan. And drug companies love for us to prescribe Coumadin, but you have to remember the way we think about it. We think about it a little bit different. What's the cost of a stroke? Okay? How much does it cost to treat someone who's an invalid from a stroke? So if we prevent one stroke, you know, we think that's worth the extra money. Okay? But the biggest problem we have, Sharon has, our girls have in the clinic, is we hear the complaints of, I just can't afford it.
But like $10 a month for Coumadin, this is $100 a month?
Well, these drugs, depending on what your insurance will cover, can range up to $300 to $400 a month. It's ridiculous. But the trouble we have is that they don't listen to us. As doctors, we have no say-so. We can get angry about it, we can make our opinion known, and more than one time we've told the reps, this is a rip-off, and take this back to your company. But you know, they say, well, it cost us, under FDA rules now, it costs us $1 billion plus to develop it, so they got to recoup their costs. They recoup it on you. Okay? So this is the problem we have. The biggest problem we have with the drugs is patients can't afford them. And some proud patients do something that's really insidious and bad, is that this drug is twice a day, for example. Rather than say they can't afford it, they just will take one tablet a day to make the drug stretch, or they'll take one tablet every other day. That is horrendous because you're exposing yourself to a tremendous risk when you take it that way. The drug has a very short half-life. If you don't take it regularly, your risk goes up. Okay? So cost to us is the biggest problem in our clinic. Now Sharon, I don't know how much of her time she spends on helping patients get the cards and all these little tricks they allow us to do to get the drug, but I would bet you that a lot of her time is spent just filling out forms to get these medications so patients continue. Because $400 a month, if you're on a fixed income, and you're spending $400 a month on a blood thinner, and you're spending on a blood pressure medicine. I mean, I've got patients who are on 10 different drugs that are new, and you're looking at drug costs per month that are over $3,000. That's exorbitant. Okay? Unfortunately, we have no power to make that better. Okay? So the drugs are definitely better, but they're costly, and that's the problem. Now, in terms of how we view the drugs, Dr. Zhao can speak to you individually about it. The way we look at this is, okay, we've got 3 drugs, we look at the studies, what's the most effective and the least risk? Well, the other issue is compliance with it. If you've got to take a pill twice a day versus taking Xarelto once a day, some patients have difficulty taking the 2-time-a-day regimen. For those patients, once a day Xarelto may be better. On the other hand, if you've had GI bleeds, the drug with the least amount of GI bleeding is Eliquis. So we tend to prescribe patients more Eliquis. So we try to individualize it, but remember, we're making guesses based on what we see in the literature. We don't know for sure, okay? The other thing we do a lot of times is a frail, older patient will cut the dose of the drugs down. For example, Eliquis will go from 5 twice a day to 2.5. So a lot of little tricks we use trying to interpret the literature. But I say the biggest problem we have, particularly at the end of the year when the donut hole issues take over, is patients just can't afford it at the end of the year. And I'm very sympathetic to that. We're very sympathetic to that issue. So a lot of times we've had to go to Coumadin at the end of the year only to switch back to the new drug at the beginning of the year. Now, what's happening in terms of non-drug therapy? Okay, this is kind of state-of-the-art stuff, but many of you have heard about these devices that are put into the appendage where the clots are formed, and they call them occlusion devices. The one you may have heard about is the Watchman device. Anybody heard about the Watchman device? Okay. Has anybody gone to a center and had a study with the Watchman? Anybody here have a Watchman device? The other big therapy is the lariat. The lariat is where this little snare-like device goes around the appendage and basically chokes it off. So this is an area of active development right now in terms of non-drug therapy. For example, what do you do for someone who's had 2 major GI bleeds and just can't take the drugs and they're in Afib all the time, and their chance score is high? Those patients may be better served with one of those Watchman type devices. The Watchman is approved, it just hasn't been rolled out yet. I think it's going to be a Dr. Zhao project. So that's basically the dilemmas we have, and I think the things that frustrate us the most is that the companies sometimes just can't make the arrangements on the cost issue. But if it were me, and I had the choice of Coumadin or a new agent, I would take the new agent. Now, many of you have gotten scared off by seeing these advertisements. Remember one thing about litigation in the United States. All the drugs can make you bleed. Okay? That doesn't mean you're going to bleed. I'm saying all the drugs can make you bleed. And so what they know is that they can't go sue the manufacturers of Coumadin because the statutes have run out. But these companies that have developed these drugs are prime targets for lawsuits. So how many of you at 8 o'clock watching TV, you see this advertisement? Have you been prescribed this drug? And have you had a bleed? If so, call this lawyer in Texas who works through his intermediaries in Louisiana, and you could be part of a class action lawsuit. I think it's very dishonest. I think it's potentially dangerous to make people overly afraid of taking blood thinners. And I've heard, I don't know of a real example, but I've heard of people around the country who have been frightened from taking their blood thinners and had massive strokes. So I wonder who handles the litigation for that. So I think we'll take some questions now if anybody has questions about blood thinners or stroke and AFib. Yes, ma'am?
Are you going to talk about Eliquis?
You want to talk specifically about?
Most of this apply to Eliquis that you went over with the Pradaxa.
Yeah, Eliquis is a good drug. It's the 3rd drug developed. Let's see, I can go specifically to that drug at the end. I've got loads and loads of slides. The bottom line on Eliquis is that what worries me a little bit about Eliquis is that if you look at the clinical trial with Eliquis, and I'll go to that specifically because you had a question. It's a factor 10A inhibitor. Eliquis had a reduction in stroke that was not as dramatic as Pradaxa, but it prevented hemorrhagic stroke. It didn't do a lot for thrombotic or clot type stroke. So in my own mind, I question whether it's as efficacious as the other. Now what Eliquis did do, if you look at bleeding risk, see if I can find that slide. If you look at bleeding risk, of course that's my summary, bleeding risk for GI bleed was significantly lower than Coumadin. I'm not sure I can find it. Okay, so if you look at bleeding risk, major GI bleeds on Eliquis were 128, that's the second line, and with Warfarin was 141. It was actually better. It's the only one that was better with GI bleeding. So that's why if you've had a GI bleed before, I don't know what Dr. Zhao's preference is, but My own preference is if you've had a big GI bleed and you need to go on these drugs, I tend to, not always, but I tend to use Eliquis more. Are you taking Eliquis? Yeah. So the only way to figure out what's the best one is if someone will do a major trial and compare them all against one another in the same population. That's called a randomized clinical trial. And until they do that, all these populations are different. You know, they've all got different selection criteria. You can be misled into looking at individual studies. So I tend to use Eliquis more in my patient population who's got more kidney dysfunction, for example, and I use it more in patients who are more prone to GI bleed.
Say that again?
I tend to use Eliquis more in patients who have significant kidney problems and in patients who've already had a GI bleed, or I think are at risk for GI bleed.
Is there an antidote for Eliquis?
Technically, no, but practically, probably yes. The FDA doesn't allow us to say it, go promote it, but there's a substance in the blood bank called activated prothrombin complex C, which is a very expensive blood replacement product that if you give that in someone who's on Xarelto, and it has been given in the emergency room for patients who had brain bleed, it reverses it. But it doesn't reverse it as fast as Praxpon does for Pradaxa. So the answer to your question is yes, but not officially.
It's coming. So that's why it helps for them to know what you're on.
Yes.
You
Definitely.
get
You can't dialyze it off. You know, you can't well, you can't give vitamin K like you do for Coumadin. It doesn't do anything. Now, we are told because they can't pre-sell this stuff. It's an FDA requirement that the reps not tell us what's going on. But if you read the literature, each company has their own specific antidote under development, and we're led to believe that this will be available before the end of the year. We are led to believe. So probably all are going to have their own individual antidotes. It's a big thing because if you're in a car wreck and you're bleeding from multiple places, the antidote issue is big because you can bleed to death. You know.
What's the protocol for dental work? Once you're on the blood thinners, or regular dental work, or if you have to have procedure?
Well, for routine cleaning, it's not that big an issue. The dentist a lot of times will just keep, going through it. Now, if you need root canal, I would stop it. The drugs have short half-lives. For example, Xarelto, you only really need to stop that 24 hours ahead of time. We can never tell our surgeons 24 hours. They can't get Coumadin out of their head. They'll stop in 5 days. No matter what we tell them, no matter how much literature we send to them, they're going to say stop in 5 days. But practically, any of these drugs is roughly 2 days. You stop it before.
And that's for any surgical procedure, not just dental?
It depends on the severity. Like if you're going to have major cranial neurosurgery, we would stop it 4 days ahead of time. Minor surgery, roughly 2 days. A common thing we see in our patients is screening colonoscopy is a big deal, and the GI doctors, they make us clear patients, and what we usually tell them is, well, the drugs get out of your system pretty quick, so all you need to do is really stop it a day or two, and they say, no, we don't, no. Stop it 5 days at a time. So whatever we tell the patient, whatever they tell the patients, yeah, because you're at risk for stroke.
Yeah.
So, but they're terrified of bleeding. See, they're not worried about the stroke. We're worried about the stroke. They're worried about the bleed because they're going to go in there and cut a polyp. They don't want that thing bleeding. So, but
Pain injections.
What's that?
No pain injections.
Or pain injections.
Have to stop.
Neural?
Yeah, when they have to stop.
Yeah, they have to stop. Those are the biggest risk procedures because if you bleed into your cord, that's a big deal. And those patients I usually do stop at 3 to 5 days ahead of time. But there is a risk. I've got a 44-year-old gentleman at West Jeff who had a minor hernia repair, and his CHAD score was 0, and he was on Coumadin, and the Coumadin was stopped, and he had his abdominal reconstruction hernia, and he had a massive stroke. And now it's a mess. So remember I said these are not absolute things, that just because you have a CHAD score of 0 doesn't mean you can't have a stroke. And just because you're on a blood thinner, if you look at the stroke risk on all these, let's go back to Pradaxa. let's go back to Pradaxa. Sorry. If you look at the stroke risk on Pradaxa, this is a study that, let's just take, we'll take Eliquis. If you look at those numbers, that's not a zero risk. Even though the curves are better, okay? Warfarin, you had more strokes, Eliquis had less, but the event rates are not zero. Okay, and that's something we always tell patients. These drugs are relatively protective, they're not absolutely protective. You can still have a stroke, although the risk is lower, and the strokes tend to be smaller. Yes, sir.
So is the only reason that someone would take warfarin would be the cost and all?
I think so.
Okay.
Not everybody would agree with me. There's a big caveat in all the releases of these drugs, because part of the reason these drugs were better in the trials, because so many patients, the INR values were fluctuating all over the place. So the caveat reads, there's no data to suggest they're better if your INR is in a tight range. Okay? I personally believe the drugs are better. If it was me and I had my choice and I could afford it, I would take any one of these drugs over Coumadin. What's the other advantage? You don't have to have your fingers stuck all the time, and they're not subject to the dietary things that you have to worry about with warfarin. Warfarin's so much cheaper, though. You know, if you look at the market share among these different agents, 5 years after they're out, warfarin still dominates because of cost. How many patients are going to be able to afford, $300 a month if they got to pay that? That's a lot. If you're on fixed income, if you're on Social Security, and you take in 5 other drugs that are $300 a month, that bill just, you're living basically to take pills.
How do drugs like Sotalol fit into this picture of,
Okay, so Sotalol is an so-called anti-arrhythmic drug. It has nothing to do with the clotting. So the mainstay of medical treatment for AFib is usually a drug to prevent the AFib from coming, like Sotalol, and a backup drug to protect you from the stroke risk. These drugs have no effect at all on how much AFib you have. Now, you could argue that if you reduce the amount of AFib with a good antiarrhythmic, you may need the blood thinner less. That's an unproven assumption. So Sotalol has no effect on clotting at all.
so it does have an effect on the AFib?
On the AFib frequency in some patients. It doesn't work in many. That's the trouble with all these drugs, is that they don't always work. Nothing works effectively 100% of the time in AFib. And even our procedures are not guaranteed cures. Okay? We always are very cautious to tell patients that the biggest risk of a procedural approach to AFib is the procedure may not work. The best we can do on a first try is a 20% failure rate. I mean, 80% successful and 20% fail. So that's not great. It's good. It's not great. Yes, sir.
If you have a hernia operation, they take you off of the blood thinner?
Surgeons take you off blood thinners for anything. Try to find a surgeon who will operate on you with Coumadin.
There are a lot of people walking around with AFib that don't have any symptoms and don't know.
1/3 of patients with AFib have no symptoms. There's a retired neurologist on the West Bank that's a Mayo-trained neurologist who's been in AFib since he was 25 years old, and he's 69 and he's going to retire to his place in Massachusetts.
And what, he has no symptoms?
He's never had a stroke. He takes Coumadin. He's always taken Coumadin. He didn't want to take one of the new drugs. He's totally asymptomatic. He runs a mile or two a day. He's totally asymptomatic. AFib doesn't bother him. Other patients that go in AFib, it prompts a visit to the emergency room. They're on their knees. They're short of breath. So it takes a wide spectrum in everybody. Why? We have no idea. Take the same patient, same age, same heart function. One's brought to his knees by it. The other just goes about its activities.
So the less AFib you might have, does that mean your chances of anything serious like a stroke or anything like that happening are less?
Well, it makes logical sense that'd be the case, but there's some data to suggest just the very fact that you've had AFib means there's some chronic inflammatory state that can make you more prone to clot. So the assumption is, well, if AFib causes stroke, then the less AFib means less stroke risk. But that hasn't been really definitely proven. Because until recently, we didn't have a good way to really measure how much AFib somebody had. Now we've got these little event monitors that can track it pretty well. So maybe that will be borne out. So I can't tell you for sure. It makes sense, but it's not proven.
If the drug for AFib almost stops it completely, then Warfarin would be fine?
Well, no, I'm not sure that's correct. You're saying if the Afib burden, the amount of Afib is almost zero, Warfarin might be okay? It depends on what time and therapeutic range you're in. If you're out of range all the time, it may not be good. If you take Coumadin and your INR is consistently good, there's no data these drugs are any better. The studies had patients that where their INR was fluctuating all over the place.
And you're obviously at greater risk in the learning curve in the period of time that you try to see what you're taking it to see when you get tested, whether you...
Oh, when you it's called drug initiation, when you first start, yeah, it's fluctuating all over the place.
So your risk is higher during that period as well?
It is, I think.
Depending on how long you do it.
Mhm.
If you're in the treatment, are you aiming for no episodes, or you are allowed a few episodes?
That's a good question. That hasn't been, believe it or not, you'd think we'd have all these answers with all the thousands of AFib patients. There's a lot of controversies in AFib. So what you're saying is less AFib means better outcomes. Have you ever heard of what's called the Affirmed Trial? So if you look at, okay, so here's a common question we get. If I have less AFib, does that mean I'm going to live longer? No, but that's a common question. Or, I have AFib, does that mean I can expect a lower chance of living to be 85?
No.
Well, if you have no other disease, there's no data that the AFib shortens your lifespan. Okay? But, if you've got other problems, if you have coronary disease, the AFib does become an independent risk factor. Your longevity is reduced. If you're otherwise healthy, no. I guess one way to summarize that is AFib by itself is not inconsistent with long life. Okay, it depends on what other conditions you have that are linked to it.
But I mean, how many episodes of having AFib are you allowed before you decide to do something else?
How many episodes are you allowed
To go
before?
into AFib, if you're under treatment with the Moltox and Eloquent.
So if you're on treatment, let's say you have a little device under the skin called a link recorder, or you have a pacemaker. So the question would be, at what point does the doctor get worried and not to change the medicine? Is that?
Or do an invasive procedure.
Or do an invasive procedure? Well, to do an invasive procedure depends on how bad it's bothering you. Okay? But at what point does the doctor get worried about changing the medicine? That's a great question. I tend to get worried when the AFib burden starts going above 5%.
5% of what?
So AFib burden is the total amount of time you're in AFib.
Oh,
So if you're in AFib 5% of the time, and provided we can track it, I start thinking the medicine may not be as effective. So I tend to either go up on the dose or I change medicine. But let's say your AFib burden is 1%, every time you get it, you're on your knees because it's dragging you to your knees. And I may say at 1% burden, I'm going to change your medicine. Depends on your symptoms. A great question that's debated at the national heart rhythm meetings is a bunch of gurus will get together and they'll say, well, we've got this patient who's 55 years old and he was found to be in AFib and he's totally asymptomatic and he has no risk for stroke. What do you do for him? He's got no symptoms. Most people would try to get him back to normal rhythm once, but what if they fail? Do they subject that patient then to a procedure? What's the downside of doing the procedure? You may have a bad outcome. You could hurt people doing procedures. But this is debated. You wouldn't believe these debates that You know, people who've been treating AFib for 30, 40, I've been doing it for 30 years. They have these meetings and say, what's the best thing for the patient? Well, you gotta remember, every time you do something in medicine is an equal and opposite risk, right? So let's say, oh, we're gonna go fix his AFib. We're gonna go put him through this surgical procedure and we can fix his AFib. What if he dies in the procedure? You've taken somebody who has no symptoms, you put him through a procedure and they had a bad outcome. Or what if you put him through a procedure and they have a stroke in the procedure? Well, he was doing great before you got hold of him, right? So that's a debate. So we tend to reserve procedures for patients where the AFib is bothering them. And most of our patients, almost all of our patients have been symptomatic. We almost never push anybody to go do any procedure if they're not symptomatic. If you're totally asymptomatic, sometimes the risk of the treatment exceeds the benefit. It's an individual call on everybody. Yes, sir.
Being specific, I'm a recent AFib person, and I had 4% when I wore the Holter monitor for 48 hours.
Mm-hmm.
And that was most probably 2 months ago. And you're my doctor. I just wore it again for 24 hours,
Mm-hmm.
and I was told I had nothing. No evidence of
We
it.
think that's good.
Yeah. Is there a point where, what do you do? I mean, do you
Okay,
ever
so-
get off of the medication?
So what happens when you're a new patient and you've had a lot of AFib and Dr. A puts you on drug B, okay? What happens is, once you start breaking the pattern of it, there's a saying, AFib begets AFib, so the more you have, the more frequent you have it. It's a case of the body working against itself, which is rare. Most of the time the body tries to repair itself. In AFib, it's just the opposite. Once you start going into it, the atrium actually remodels itself to facilitate you staying in AFib. But once you start breaking the pattern, the episodes start becoming less frequent and the duration gets less. So typically we'd watch you a little bit longer. And then what I typically do is, if the AFib pattern is going way down by 12 months, I tend to stop the medicine and relook at it again. Because otherwise, we're going to subject you to medicine for the rest of your life. I mean, think about that. That's what a lot of people do. They put you on a medicine and never reevaluate it. But what if you don't need it? So all the drugs have some side effects.
So I'll be on medication for a year.
That's a rough rule of thumb.
Yeah.
It's a rule of thumb I've been using a long time, that I'll treat for a year, and if the Afib burden essentially becomes zero, I'll stop the drug. What I won't do is stop the blood thinner. Because think about that. If I then take the risk of getting you off the drug and you go back into Afib, I want that last line of defense against stroke.
Would one be, I mean, this is a surgical procedure, I guess, putting that reveal?
Yeah, that's a minor procedure. We don't call it a surgery.
Okay. I mean, would you be put on that to determine whether you've gotten off AFib?
I got to be honest with you. I'm one of these people that thinks that everybody with AFib should have a reveal. Because otherwise we keep repeating the same questions over and over and over again. You keep getting monitored and monitored, and you know, the beautiful thing about the reveal or the live core, anybody having a live core device on their phone? Sharon can show that to you if you like. The thing about the live core, it doesn't monitor you during sleep. But if you have a reveal in, that little microchip, we can know with exact certainty how much AFib you have. I think it's critical. Let's take a scenario. Let's say you do great for a year, and let's say you have no symptoms of AFib. Okay, let's say it was accidentally found. And let's say we treat you for a year, every time we do an EKG, every time we do a monitor, you're not in AFib. And then we stop the medicines. Well, how do we follow you? Your symptoms don't tell us if you're going back into AFib. How do we know that the process is not getting worse again? That's where I think the reveal comes in very handy to us.
So after that year of monitoring, and the patient is seen, everything is revealed that he's okay, would you put in that reveal or not?
If the patient would agree to it, I would.
If the patient...
I don't put them in. I usually have somebody else put them in. I mean, I would do it for me. That's always my goal, my test. Would I do it on me? Sure, because I want to know.
Yeah.
How would you know? If you now, we have patients who can tell you every time. I'll look at their logs, and every time they go into AFib, on their logbook, and if I've had a monitor on them, they can tell you to the minute they go into AFib. That patient doesn't need a lot of monitoring. Their warning system is so good, I can look at their logbook and know how much. The majority of patients don't always know when they go into it. Those patients, the monitoring becomes a better option. So how many times can you keep putting these monitors on? People complain about them all the time to us. The electrodes hurt, they irritate my skin. You know what the cost of monitoring is for 30 days? Like $5,000. It's a ripoff. Okay, we've got to keep putting those monitors on you. I mean, that's ridiculous. I'd rather have the Reveal for me. So if you have a pacemaker, it's the same thing as a Reveal.
If you have an AFib episode.
Now remember, different doctors will give you different opinions. There's honest differences of opinion about what's the best way to follow. I think that's the best way to do it.
If you have an AFib episode, is there anything you can do to stop it or slow it down?
That's a great question. If you've got other rhythms, yes, there's little maneuvers you can do. In general, for AFib, there's nothing you can do once it starts. Now, some people have, there's some stuff in the literature where if you practice deep breathing exercises, sometimes that helps. For the most part, there's nothing you can consciously do. We don't have that ability as human beings to break the AFib with thought. They're experimenting with that, actually. They're looking at meditative techniques to break AFib. It's kind of interesting. But in general, no. You can rest. How many have had AFib precipitated by some emotional stress? Getting angry, that's a common thing. Anger. And, AFib is one of the most neurally mediated arrhythmias. Chronic stress. You've been to the support group before, you know my opinions on caregiver stress. It's amazing how someone can have no AFib till they're 60 years old. Mama who's 82 gets sick, you've got to take care of it, and within 1 week you have an intractable AFib. I've seen that so many times. So this is a very stress-related arrhythmia. So remember the big 5 things we always look for in the office: caffeine intake, alcohol intake, tea and chocolate intake, nasal decongestants, particularly around flu season, and undiagnosed sleep apnea. That's the big 5 we always go look for.
What are some of the worst nasal sprays?
Anything with pseudoephedrine in them. Nasal steroids, things like Flonase, don't trigger AFib.
Pseudo what?
Pseudoephedrine, P-S-E-U-D-O, ephedrine. It's like pure adrenaline. That's how we induce AFib in the arrhythmia laboratory. So nasal steroids, let's say you have seasonal rhinitis, seasonal allergies, and you take Rhinocort or Nasacort or Flonase, they don't have that. But if you take anything with D on the end of it, classic example, Mucinex D. Okay, the D is danger. Regular Mucinex is okay, it's just an expectorant. It doesn't trigger AFib, but Mucinex D does. A classic one is NyQuil. How many times have I heard a patient, never had AFib, it's a bad cold, takes NyQuil. Of course, he doesn't take just the one little cup of NyQuil, you've got to take 2 or 3 of them, because basically NyQuil knocks you out too. Anytime you put alcohol and Benadryl together, it knocks you out so you can sleep, you can get rest. How many times have I heard patients take a big slug of NyQuil and they go into AFib that night? That's a classic story we hear. So those kind of things, those ingestions, I call them, ingestions of things for colds are really big triggers for AFib. We see it a lot. The physical act of chugging a cold liquid, because the esophagus is right behind the left atrium where the AFib is triggered from, A classic example of that is the guy in summertime who goes cut his grass at 10 in the morning, feels like $1 million, he just cut the grass looks great, he's thirsty, his wife brings him this big old jug of cold water or tea, and he goes, chugs that cold liquid and goes into AFib. That's another classic one.
Is chocolate contributed?
Chocolate in high amounts, small amounts of chocolate probably don't. You have to eat a lot of chocolate. Or strong tea, strong green tea could also do it. Some people feel the NutraSweet type things contribute. Other people blame Chinese food with monosodium glutamate. We've got patients who swear by certain foods that trigger it. In fact, maybe a trigger for them, we just don't know. But for us, the biggest ones are caffeine, particularly with these high energy drinks now, which is loaded with caffeine. I mean, caffeine concentration in Red Bull is like 4 or 5 times what a cup of coffee is. We see that a lot. Those drugs, those cans of stuff are more popular with young people. That's why we see more young people with AFib now.
Pain?
Hmm?
How many times when they fall down, they get hurt?
Pain, chronic pain.
brings it on.
Yep. She hears all this stuff, so she's an expert too on it. In terms of the stress, it's the biggest stress. You know, obviously loss of a family member is a huge stress, but the one we see more than that is caregiver stress. It's usually a woman, because the men always run away from it. a poor lady who's, and it's the conflict between, I'm giving my life now for mom, and now my life is basically subjugated to taking care of her. It's that same thought process that puts you under a conflicted stress you can't resolve. There's no way around it. Because you don't want to be disloyal to mom or dad. By the same token, you want a life too. That conflict gnaws at you day and night, and it creates adrenaline. All stress is adrenaline. And the way we induce arrhythmias in the laboratory is to give adrenaline. So any other questions about blood thinners?
Yeah, does any of the blood thinners prevent or reverse blood clots?
They don't dissolve the blood clot. What they do is they prevent further. The body's own clot-busting mechanisms will break up the clot. What the drugs do is prevent propagation or enlargement of the clot. So they're not clot dissolvers. So for example, you may have heard of TPA. It's a drug that was developed to break up a heart attack. That actually dissolves a clot. These drugs don't do that. They just prevent growth or formation of clot. So if there's a clot there and you start this drug, the clot will wither away based on the body's own mechanism. It's not because the drug dissolved it.
Okay.
I mean, there are clot dissolving drugs. TPA is a classic example of it. Yes, ma'am.
I saw that you had mentioned briefly before about the difference with the aspirin with the protection of the platelets, which for a lot of people who don't have AFib, they take an aspirin for that purpose. If you have a risk of MI or those heart issues, do you ever take an aspirin? Because once you stop taking the aspirin, you've obviously eliminated the protection of that.
Our worst nightmare is someone who's had a stent and they're on Plavix. They're on dual antiplatelet drugs. They're on Plavix and aspirin, or aspirin Effient, or aspirin Brilinta. They're on dual antiplatelet drugs, and then they develop AFib, and they have to go on one of these. So what do you think adding 3 drugs that cause bleeding together, A plus B plus C, does to bleeding risk? It doesn't just go up additively, it goes up like a rocket.
So you'd almost never voluntarily take an aspirin along with blood thinner.
If you, we advise if you take an aspirin for another reason, that we try to get you off of it, because the additive risk is too much. Aspirin has a lot of good effects for a lot of other things. I mean, for example, your risk of colon cancer is 50% less if you take aspirin. I don't know if you've ever heard that, but it's an amazing drug. But these two things together, the bleeding risk goes way up.
Some sulfa drugs make your blood too thin in that.
Sulfa drugs, you mean antibiotics?
I'm not sure. One of them I took, and it got so high they had to give me a shot of vitamin K.
You were taking Coumadin at the time,
Yeah.
right? So that was the interaction between that drug and Coumadin.
Right.
Yeah. Yeah, okay, there's a lot of it, there's loads of it. Coumadin interacts with everything. The list of interactions with Coumadin is amazing. Our fear is when we start patients on amiodarone with Coumadin, the amiodarone and the Coumadin have an interaction where your bleeding risk goes up 3 or 4 times. That's why we have to have you check the INR every week. That's a combination, but everything interacts with Coumadin. Red tomatoes interact with Coumadin. It's vitamin K. Makes it less effective. Other drugs make it more effective. That's why we hate Coumadin. It's cheap, but it's so treacherous to use.
Can you talk about what antibiotics you can take or not, or painkillers you can take or not?
You know, there's so many different answers to that. Probably the best thing is if you're worried about it, if you just call us. It's better for us to check because the master list keeps growing and the antibiotic list keeps growing. In general, most antibiotics you can take in general. There's a couple of antifungal drugs like ketoconazole. If you ever use that, it interacts with all of these drugs, all the new drugs. But the list is so enormous, it's better if you have a question just to ask us about it.
The list of what not to take?
No, if you're prescribed something by another doctor, it's probably best if we do it. Now, what will happen is, the trouble we have is that the pharmacist will say, let's say we're treating you for Afib and you're on Eliquis. And then Dr. B sees you for a cold and he puts you on an antibiotic. And then you go to you fill that and your pharmacist says, oh no, you can't take that because you're on this other drug. Okay, so 99 times out of 100, those interactions are so minor not to worry about. But what the pharmacist has done is now scared the living daylights out of you. And so it's better if you call us. Because the pharmacist says, oh no, don't take that, it'll kill you. That's just, they over dramatize the interactions. Most of the time those interactions are minor interactions, they're nothing to worry about.
What about pain, like Tylenol, ibuprofen, or anything?
Well, the issue's the same because the non-steroidals, not Tylenol, but the non-steroidals additively add to bleeding risk, particularly GI bleeding risk. So if you're on a leave, for example, let's say you're taking a leave over the counter, even over the counter Aleve added to Coumadin or added to Eliquis increases the bleeding risk. Not by a lot, but by enough to be significant. So if you have to take, let's say you have rheumatoid arthritis, that's a classic one, and you're on prednisone, and you're on a non-steroidal, and you're on Eliquis. Well, the non-steroidals and the prednisone destroy the gut lining. The medicine makes you bleed. It's a setup for problems. I can think of 100 scenarios like that. It's probably better just to ask us.
And that's the same risk for wanting an occasional cocktail or the alcohol, because the alcohol in your stomach just does not do well. I mean, it just increases your...
We usually don't restrict alcohol on everybody, but, one drink is one thing, but, a bottle of wine is probably too much. It's a lot.
And with food, too, I would imagine, instead of on an empty stomach.
With food,
With food, I mean, if you have a cocktail, have it with food.
that's probably better.
Yeah.
Yeah. Any other questions?
Well,
Yes, sir.
if all you have is like aspirin, if you get a headache, you don't have access to Tylenol, you still wouldn't take the
It's not the one aspirin, it's the chronic use of it.
Okay.
If you've got a bad headache and you take one aspirin, I doubt, I've never seen a scenario where taking one aspirin would cause a problem. It's to taking the aspirin every day with the other blood thinner. That does increase the bleeding risk because we've seen bad examples of it.
So if you're taking like 4 or 5 a day,
Taking
that's too many.
4 or 5 aspirins a day with
Yeah.
one of these drugs?
Yeah.
That's like a skull and crossbones.
I know,
Now, most people get away with it, particularly if you're younger, you can get away with it, but older patients tend to not have that tolerance. All these effects are, the older, in general, the older you get, the less defense you have against the side effects. So a 40-year-old, 50-year-old man may get away with a combination of Xarelto or Eliquis or Pradaxa with aspirin every day, But it may reach a point where one day, 45 years old turns to 65 years old and the risk goes up. We don't know when that happens, but if you take aspirin, we always, I mean, my patients who are here will tell you, we always try to get you off aspirin if we can, if you're taking one of these drugs. So what's the ones that additively add the risk? If you're on, let's take the example of Coumadin or Pradaxa. Either one of those drugs plus aspirin, bleeding risk goes up. Then you add a drug, if you've had a blockage in your heart artery, let's say Plavix, risk goes up a lot. Then you take a non-steroidal on top of it for joint pains, it's like off the ceiling. The risk of bleeding. You're going to bleed sooner or later.
I know, I think Advil is, helps with inflammatory, I think?
They're called non-steroidal anti-inflammatories.
Okay. What would the doctor prescribe to lessen the inflammation, if you get hurt or anything like that, if you can't take a leave, 4 or 5 times a day?
Well, normal people, I mean, people who are not on other blood thinners, that's fine.
Right.
We're talking about somebody who's going to have additive risk with these additive drugs.
Okay, so if you're on Pradaxa, the only thing that you're on, and maybe your rhythmic drug.
Pick Sodalol. Pick
I'm
any
on
one of them. Amiodarone.
Amiodarone, that's the one I'm on.
Okay.
So, let's say if I get hurt or something like that, I could still take a leave, 3 or 4 times a day for a couple of days to keep the...
Yeah, it's not the once or twice a day. I mean, the theme is that it's not the once a day, 1 day or 2 day or 3 day or a week. It's the 3 months, 6 month,
Oh,
a
okay.
year that we're warning against. I mean, it's very unlikely a couple days of Motrin, for example, or leave are going to interact that much. Theoretically, it's possible. I almost never see that. So if you fall and you hurt your shoulders, for example, and your doctor prescribes prescription strength Motrin, and you're on Pradaxa, 99 times out of 100 we get away with it. But take it for 6 months, we may not get away with it. Yes, sir.
Colonoscopy, you get off the Eliquis 3 days ahead of time and 2 days after?
No matter what we tell you, they're going to tell you to stop it a week ahead of time.
So what do?
And we can't fight it either.
Listen to them or listen to you?
Well, because they won't do it. It doesn't make any difference what we say.
Well, how are they gonna do it?
Well, because they're going to say, when did you stop your... Is it Dr. McKinnie said only need to stop at 2 days ahead of time? No, we're going to reschedule your colonoscopy.
Okay. What about, do I have to get off the Multaq?
This is true. This is not something I make up. This is...
Okay.
Can't you just
They do this to us. We've got patients come in and say, you told me, they're angry at us, you told me that I only needed to stop at 2 days ahead of time, and my GI doctor got angry and he said, no, I want you to stop 5 days ahead of time. So the GI doc's angry at us and the patient's angry at us.
What about the Multaq? Do you stop that by colonoscopy?
No, Multaq's an antiarrhythmic drug. You don't need to stop any antiarrhythmic drug. I'm serious. These are things we get phone calls about, It's happening less and less because we gave up. But from a pharmacokinetic standpoint, if you stop Eliquis 2 days before a procedure, it's basically out of your system. Okay? You don't need to stop it 5 days at a time.
But you can stop at 5 days and not.
Yeah, but what happens if you're an Afib and you're a high-risk patient? Every day you're off of it, technically,
So it's better just allow it to, so you were all 5 days.
well, I didn't say that. I can't say that. But from a pharmacokinetic standpoint, most of these drugs are out of your system in 2 days. They will not do the colonoscopy unless you've been off of it for 5 days. So I don't fight it anymore. I got enough battles.
But that is putting us in danger though, isn't it, for stroke, for 5 days, huh?
If you're in AFib, yes.
Oh, well, you're not in AFib.
If you're not in AFib, the risk is less.
Less.
Yeah.
But who knows that?
Who knows that?
I'm just telling you the real world. They won't do the colonoscopy.
I've had 5 major surgeries and every single one of them was 5 days.
Yeah.
5 days ahead of time, but they wouldn't do it.
And you get
Because
cut.
for some reason, I can't get it into their heads that this is not Coumadin. And no matter what I do, and sooner or later you say, I don't need to be fighting windmills.
I think something too, I don't know if it was mentioned earlier, but some of the anti-rheumatic drugs also act as a blood thinner with Coumadin. Is that so?
Amiodarone is the classic example of that.
That's the one I want.
So here's an example. When let's say you're on Coumadin, and we say take amiodarone, your blood gets thinner and thinner. You know, it'll reach an equilibrium, but it'll get thinner, and you have bleeding risk. If you come off the amiodarone, the blood gets thicker. So that's the classic one that we worry about the most.
In 1 week, it went from 2.5 to 4.1.
Well, we've seen big bleeds. That's why we check it every week. We check it every week when we do that.
Right.
I mean, our nurses are trained to do that.
Do you check the blood for Eliquis at any time?
No, another common question is patients, a lot of patients are so in tune to being checked, and they won't believe, and I'll say, you know, in the studies, when they checked 18,000 patients' drug levels every day, 3 times a day, the drug didn't vary much, so you don't need to routine check it. You say, yeah, but I don't feel comfortable with that. But you don't need to check the drug levels. You know, across a wide range of weights, when you take these drugs, the levels are such that you don't need to check it. When we can check it, it's a big send-out, it's a very expensive test. But the FDA advises no routine monitoring of INR for these drugs. That's an advantage of using them. The total cost of using them is actually less. That's why there's so many better advantages of using the new drugs than Coumadin. The trouble is Coumadin is less expensive. And I understand that. I don't get down on folks when they say I honestly can't afford it. Sharon and the girls do everything they can to work with the companies to get them samples. We sample like crazy. We're very generous with samples, but some patients it's just too much because they're on 5 other drugs. Or if you're on some of the new anti-cancer drugs, it's like $80,000 a year. It's a ripoff.
So, you telling me I can just go to the window and ask Brittany or Sharon for some samples?
Yeah. Yeah.
Okay.
Yeah, we do it all the time. Sure. We're very generous. We just keep hounding the reps. They bring us more. I go to West Jeff too. My office at West Jeff, they won't let us sample. West Jeff has a policy not allowing us to sample. East Jeff allows us to sample.
Stay with East Jeff.
Yeah, well, I go to both. I run the arrhythmia programs at both places. So yeah, we can't sample you enough to where this place is all.
I don't have to buy it, huh?
No, we can't give you that much because then nobody else gets any benefit of it. We try to be as generous as we can. Yes, sir.
Do you know if most insurances, or if any insurances, will cover at-home INR test monitoring?
Most do.
Okay.
Have you had problems sharing with them?
Not really, but I thought most of those, are you talking about if somebody comes out to your house?
No, you do it yourself.
Oh, do it yourself.
Home INR.
The insurance is probably covered.
Yeah, they usually want you to do that.
You just have to get it to whatever cardiologist is,
Right. That's handling.
is,
Right.
managing it, right?
That's right.
So what I'm trying to do is give you an overview of the new drugs, why we think they're important. The main thing is that you treat it with something if you need it, whether it's Coumadin or one of these. I personally think these are better, particularly when the antidotes come out. I feel better. A lot of patients are reluctant because there's not an antidote for their particular drug, but that's all coming by the end of the year, we're told. So we'll see. What's that?
So we're led to believe.
We are led to believe.
Might take a couple of years, you never know.
Well, Pradaxa has one already. Praxbind is, believe it or not, it's not in the formulary yet. So if something happens, they got to go run to another hospital and go get it. But it's coming.
And
Everything at EJ goes through multiple layers of bureaucracy before it gets done.
Without if you're on the other ones, and you said the drug that, let's assume every emergency room may not have that.
Activated PCC.
So, but not every place Like if you're in an isolated area or a small
There's a
hospital?
possibility if you were in Bunkie, Louisiana, if you went to their hospital, they may not have activated PCC.
But, so what do they do to you if you go in as an accident?
They call for it.
Yeah.
You got a problem. That's why some patients are reluctant to take these. Because patients are pretty bright, you know, everybody can get on Google and punch in the drug name, and Google comes up with this paragraph: there is no known antidote to this drug.
Right.
I never used to have patients come in and say, I'm worried about the antidote issue. Now everybody comes in and says, I'm worried about the
But
antidote.
I mean, even blood transfusion can be an option, or is not necessarily a safe?
Replacement of blood won't reverse the effect.
So you'll just bleed out
You
of what's in
you
you.
could. It has happened.
If we on a blood thinner, should
We
we
had a
wear a
patient,
medical alert?
hmm?
Blood bracelet, if we're on a blood thinner, should we wear a medical alert bracelet?
I think so. I think so. I think it's a good
Otherwise,
idea.
How would they know?
Hmm?
Otherwise, how would they know if you're bleeding out?
Well, Big Brother one day is just gonna have the chip implanted in your skin where everybody can know your whole medical history anyway, so. That's what these electronic medical records supposed to be for your privacy. Now, everybody in Russia has your medical records. At least when you put it on paper, you could lock it up. It really was confidential,
Why do we have to sign that HIPAA thing then?
because that's what the government tells us we gotta do.
But it's all out there now.
You think we have any power against that? All right, folks, what are we doing next? Oh, Dr. Brothers is gonna really take us on a guided tour of his really good procedure. A gifted person. I've come to believe he's the best arrhythmia surgeon in the South.
And what is his procedure?
He's going to talk about the hybrid convergent procedure. He may talk a little bit about non-drug treatments. He does a beautiful job. I didn't mention it, but patients, because we don't have the Watchman, there's patients who've had big GI bleeds. He's able to take a little scope through the chest wall on a very tiny incision and get that appendage and basically get rid of it. It saved several patients' lives already. He's a very skilled person.
Is he located at EJ?
Yeah. He's going to talk about the procedure to fix Afib, which we think is the best option for many patients. There's no guaranteed fix, but this comes closest, we think. He's going to, that's next 2 months from now, right?
Right, first Wednesday of June,
We're going to film that one, right?
we're gonna film.
We're going to film it.
Actually, he's filmed already, but he's got updates.
This is the updated,
Yes.
the updated film.
The other one's a couple of years old.
Any other questions?
Now, is this different than the procedure that you mentioned 2 meetings ago?
Yes,
Okay.
difference between cryo and convergent.
This is different. This
Okay.
is different. The cryo balloon is done only through the leg vein. This is a little incision done here.
And
Tell them
the
it's all.
success rate is about the same, or one's?
Well, it depends on the type of AFib. The come-and-go AFib, we typically do the cryo balloon through the leg alone. If you've been an AFib for a long time, Dr. Brothers' procedure is the best procedure. We've come to learn that. There's a big problem with the way, you see, the trouble with AFib is that nobody really knows what it is. We don't understand it very well. We know certain things work, but we don't know why they work. So until the science catches up with what we do, we're never going to have, you know, the best thing is to have a procedure that works nearly 100% of the time and has almost no risk. Take, for example, an appendix. The surgeon says, I'm going in and take out your appendix. It's almost 100% he's going to come out with an appendix. And the risk of an appendectomy is not zero, but it's close to zero. We're not there with AFib yet. Okay, we're going to wrap it up. I'm glad everybody came. If you have anybody who wants to come, this is a public forum. Anybody's welcome. If you have friends who have AFib. And then you'll love hearing Dr. Brothers next time. Thank you.